I think I'll just open it up with a question, an observation. What populations, and I think this is outlined in Russ's paper, I think this might give him a chance to respond to Jim's comments there. What populations are we really thinking about when we're talking about the ones that are going to be amenable to some mix of incentives, push, pull, financial or otherwise, to improve health?
Well, this on? I think that's a very fair question, and I think that goes to David's points about being very careful in the selection process and the designing of an incentive plan. There's certainly going to be some people, as Jim pointed out, that may not find themselves to benefit from that because they have very deep-rooted problems that finances may not matter. So I think targeting in all these incentives has been very important, and looking at those who have manageable chronic disease, who have mental health issues that with peer counseling and navigators and others can be managed. And I think that's why you have to identify very clearly the population. It's certainly not going to be the entire universe of the Medicaid population. It's certainly not going to be the long-term, physically or mentally disabled. It's certainly not the institutional population. It's not the elderly. But I think there's a substantial number of people that are not practicing unhealthy behaviors because of genetics, but they simply practice unhealthy behaviors maybe because they don't make the right choices, as some of David's mentioned in the behavioral economics, and maybe because sometimes they believe that regardless of what they do, they're going to be taken care of from a health perspective, as Robert pointed out. And so I think that there is a fragile balance there, but I think you need to get to the population and universe that actually can change behavior. Let's not forget, although healthcare across the board is to some degree publicly financed, Medicaid is an entirely publicly financed program, and I think to have expectations of people is very important, because I think people, when they own more of their own care, tend to be better consumers. And if we can cajole, incent, or otherwise encourage that, I see us being careful in the selection process and moving forward in a larger way.
The other panelists have any thoughts about that?
Well, I had just one, and that was that it's my understanding, and maybe I'm wrong, but that in the care coordination context, whether it's for high user populations like frequent flyers in drug and alcohol abuse systems, whether it is care coordination and it is an intensely high touch relationship, but it is one that also talks about personal responsibility. I mean, I don't think it's care coordination and incentives and encouragement of personal responsibility, and they're two separate things. I think actually care coordination should include an aspect, and does include an aspect, of trying to get behavioral changes and habit changes, and that's what ultimately has proved successful in some of the care coordination pilots that have been done.
Well, and I agree. I think there is a level of personal responsibility that is inherent in what is being done already in the Medicaid program, and particularly in the care coordination arena. Frankly, the whole notion that embedded, obviously, in the Affordable Care Act, that everyone has an obligation to purchase health insurance is an element of personal responsibility, and then the notion that there ought to be efforts undertaken to make sure that people access the healthcare system appropriately and properly, get the care, all the care they need, but only the care they need, is certainly also an element of personal responsibility. Where it becomes worrisome, obviously, as David noted, I think, is that where it devolves from all of those sort of positive encouragements, education, and maybe appropriate incentives, and into something more like, and if you don't follow these rules, you will be punished.
Well, can I just make one more point about that? I only want to say this. We're in the middle of a care coordination transition in New York City in the home care program, the personal care program. And it's very clear to us that in the care coordination context, recipients of care are being instructed that their care is going to change in ways they might not like. And some of it has to do with them having to do things differently. So I think one of the things that I've observed as I've watched Jason Helgerson and others go along talking about care coordination is they don't recognize that managed care comes with it some decisions that the patient might not like. Now, I'm all right with that. I just want to be honest about that.
Having said that we should beware of the TANF analogy, I want to contradict myself and give an example that I think may be illustrative here. And it's about the We Care program that Robert mentioned, which he, by the way, gave me much too much credit for. I deserve very little credit for that program. But the idea in the We Care program, I think, was not to just accept at face value if a client comes in and says, I can't work because I have a disability or medical condition, but to do a rigorous assessment to determine whether or not that's true. If it is, in fact, borne out by the assessment, then to provide the services the person needs. If it is not, to then say, well, actually, no, we do think you can work, and or at least up to some degree, and we're going to work with you to make that possible, but we expect you to comply with that. So I think there may be a model there. The only thing I would say about that, and I think Robert would agree with me, is that is not cheap to do. It's an expensive process. It in itself requires a commitment of resources to do that kind of assessment before you get to the point of saying to somebody, we disagree with you, we think you can do this, we're going to expect you to do this.
I just want to follow up with another question before we open it to Q&A from the audience. This is, of course, not a problem that just the public sector Medicaid programs are struggling with. Obviously, private employers are increasingly trying to find better ways to get, as Robert mentioned earlier, better behavioral health out of their employees. This has led to increased effort to get something called value-based insurance design. Maybe you can call it something else. Maybe this means zero copays for some types of services like pharmaceuticals. Maybe it means higher copays for things like emergency room use that's not efficient. But what kind of lessons, and Russ has already talked about to some extent, can we learn from private sector initiatives? And then finally, have we developed, or are we developing, and maybe we have in New York State and I just don't know about it, but the kind of evidence base from the program that allows us to rapidly test, collect data, and then where appropriate implement or cease programs that aren't working? So what kind of iterative quality to the Medicaid program do we need to develop that can learn from, scale up and then learn from some of these other practices?
Well, I know there's definitely an increased emphasis in the private sector in response to your first question on looking at these arrangements. In some cases, again, not to be the naysayer, the folks who go to the exercise room on a regular basis, who join the gyms, who are not smoking, end up reaping a significant amount of the rewards, and it's not entirely clear that it's had that much impact on the folks it was obviously intended to address. And but again, there's I think there is a difference, obviously, between what steps might be taken to incent, or for that matter, to penalize people who have some financial capacity to deal with those, particularly on the negative side, than would be present within a Medicaid program. If the only thing you can deny someone is their ability to continue to get health care coverage, as I think everyone has acknowledged, that's not the right direction to go. I think the emphasis on data and outcome and being driven by evidence is clear within this administration. I think Dr. Shaw, among others, is particularly interested in making sure we know what works. And I think, as you pointed out, some of the programs that are going to be funded in the MRT waiver request, including home visiting programs, the nurse-family partnership, and supportive housing initiatives, have all the evidence in the world to support them. And I think obviously we need to continue to improve in that regard, but I think we've made huge strides.
One of the things that we did in the couple of years that I was in Washington in the Obama administration with regard to this was to sort of take a two-tier approach to replication of evidence-based programs. And we did this around home visiting and also did around teen pregnancy prevention, among other areas. And that was to sort of take a pool of funding that was available and subdivide it in two categories. One category, the larger share, would be for replication of evidence-based programs. That is, programs that have been demonstrated through, gold standard, double-blind, controlled trials to be effective, and say states or providers can use these funds only to replicate programs that we know work. But then to take a smaller pool of funding for demonstration projects around promising programs. So not just anything, but anything that has sort of been demonstrated at some level of qualitative analysis at least to be promising, and say, we do want to continue to build the evidence base. We don't want to close the door based on what we just know now. And so some proportion of funding in an initiative would be devoted to pilot projects, demonstration projects, to test and evaluate promising practices. I thought it was sort of an interesting way of both trying to shift programs to what we know works, but not close the door to learning more about what possibly may work. That might be something for the state to take a look at.
Well, I think, you know, in the private sector, obviously, the emphasis is also trying to minimize lost production. I mean, that's part of the reason they incent employees, because they look at, you know, productivity issues of their workers, and when they're healthier, they get more productivity. I just, you know, you go to sort of a common sense model of New York is looking at the whole patient issue from a perspective, I think, that's right, of providing numerous supports, you know, because the complexity of the redesign of Medicaid is real. Patients will need to understand some of the reconfiguration of the programs they access, and all of the things we do to try to hold hands in that level, I think, are appropriate. And that's much of what the analogy with TANF is, too. There was a great deal of hand-holding in TANF, case management, incentives, et cetera. And I think here, I guess the point that I think is critical here is that if you put those successful patient supports in place, it's very reasonable in life for all of us to expect some sort of reciprocal response by the patient. I think it's a pretty reasonable and rational thing. It's about normalization. It's about choices. It's about people making the right choices. And if you need to incent some people to do that, I know that the New York Post looked at this Medicaid incentive for the Prevention of Chronic Disease program and pilloried, and I think that pilloried it, and I think that's a mistake, because I think that some of the things we've talked about here today, they do show evidence that they work. They do show evidence that they change behavior. They do show evidence that they improve child well-being, that they improve adult behavior, and I think that we need to do more with them in order to know which ones really do work. And I'm not, you know, as Robert said, I'm not terribly, I don't know what the leverage point is, and have made it clear that denying health care is counterintuitive as a requirement. But there are leverage points short of that I think can be used once you have supports in place to expect certain behaviors from people who are in a totally publicly subsidized health program.
And you know, another way is medication, sticking with your prescriptions. When I was on the board of HHC, Commissioner Frieden used to talk about methodologies to be in constant communication with clients or patients about their prescription adherence and making sure that they're reminded. Now that's a little bit of personal responsibility. It's a little bit of hectoring. It's a little bit of bothering, but it is something that I think needs to be considered if people are going to get healthy.
Well, one incentive we could provide people, and it's mentioned in the paper, and it came from a long discussion with Jim Talon at the United Hospital Fund. Some of the people with the most chronic conditions are the people hardest to be in contact with, and even just providing them cell phones and providing them ways, you know, as an incentive so that you can do the hectoring and the follow-up and the talking about the meds and reminding people of appointments is a very, you know, seemingly a small sort of thing, but an important thing to help people manage their care.
And I think that was a point you bring on your paper too, Russ, is that assuming you go a little bit further down this pathway and start thinking about other opportunities, if you're thinking about some kind of capped allotment or block grant, the ability to wrap non-Medicaid services around Medicaid recipients in ways that might help to improve their health.